young children. I'd like to welcome all of our witnesses here today. We look forward to your testimony and now recognize the ranking member, Mr. Green, for his opening statement.
Thank you, Mr. Chairman. I have a statement I'd like to put into the record. I want to welcome our panels. These bills are all very bipartisan. I appreciate the chair and the majority setting them for today. But I'd like to ask unanimous consent to place my statement in the record and
without objections ordered.
Yield my time to my colleague from California.
Thank you, Mr. Chairman. Thank you, Mr. Green, for yielding time. And I appreciate the hearing on these important bipartisan bills. I'm particularly pleased that H.R. 1344, the Early Hearing Detection and Intervention Act, will be discussed here today. As a co-author of that bill, along with my colleague, Representative Guthrie, I thank you for including this reauthorization in today's hearing. Since the program it received its authorization in 2000, we have seen how vital it is for babies and their families. As a school nurse, this hits home for me too. Back in 2000, only 44% of newborns were being screened for hearing loss. Now we're screening newborns at a rate of over 98% before they leave the hospital and linking them to follow-up care, which is the critical piece. And we know that early intervention is key, helping children with hearing loss achieve academically and developing in line with their peers, but our work isn't done. And as a school nurse, I had a lot of interaction with students who were already behind, lagging from their classmates due to undiagnosed and or untreated hearing loss. We can prevent more children from suffering in the classroom through better investment in follow-up and intervention as part of the successful hearing screening program for newborns and infants. We need to ensure that every newborn is screened, every family has access to follow-up care. Early identification and intervention are key to a child's well-being, and that's what this bill would support. I'm hopeful we continue to work on a bipartisan way to move this and other bills that we're examining today and bring them all to the floor this year. So thank you, witnesses, for being here, and I yield back.
Chair, thanks to the gentlelady. Chairman Upton has asked to yield his time to Representative Guthrie, so the chair recognizes Representative Guthrie at this time.
Thank you very much. In interest of time, Congresswoman Capps had a lot of statements that I was going to make in that, so I'm pleased to be here to support 1344. I'm pleased to have co-author Congresswoman Capps, and I've been interested in this issue, early detection and screening, since I was in the state legislature. I did research when a bill was going through the legislature and learned if a newborn at the early stages, if you have hearing loss and you don't have the opportunity to hear correctly, you can never gain that back. Even if you learn it as a young adult or a teenager or whatever, you can never gain it back. So it's important to do it early. It's early detection. And the current law is set to expire in September of 2015, a mere 3 months from now. And these services will go away, and we'll lose the opportunity to catch these early screenings. So I'm pleased that Chairman Pitts has put this on the agenda for today. This bill appears to be moving forward, and I appreciate working with Congresswoman Capps, and I appreciate your time, Mr. Chairman, and I yield back.
Chair thanks the gentleman. Thank him for expediting as well. Chair now recognizes the ranking member of the full committee, Mr. Pallone, for his opening statement.
Thank you, Mr. Chairman. Did you have a statement on the other side? Okay.
Yes, we did.
I know you're trying to get it done fast here. Let me thank Chairman Pitts and Ranking Member Green for holding this hearing on an important piece of legislation that will surely improve the health of our nation. I'm pleased that all three bills have robust bipartisan support and continue this committee's tradition of a thoughtful, collaborative approach to public health legislation. I'm not going to read all the bills. I mean, obviously, H.R. 2820, a stem cell therapeutic research reauthorization act, it continues the highly successful Be the Match registry for bone marrow, and this bill ensures that this critically important program continues to operate. As far as H.R. 1344, the Early Hearing Detection Intervention Act, introduced by Representative Capps and Guthrie. Obviously, this is important for newborns who now are regularly screened for hearing loss, and so this is something that we support. And finally, H.R. 1462, Protecting Our Infants Act of 2015, is a greatly needed piece of legislation to address the sad reality of our country's opioid epidemic. This bill rightly recognizes the immediate need for a comprehensive national strategy to address prenatal opioid use. So I also thank Representative Clark. She's talked to me about this in the past. Look forward to working you and our colleagues on these important public health bills. I yield the remainder of my time to Representative Capps. She already spoke. I yield back. Thank you.
Chair thanks the gentleman, and Chair recognizes Mr. Green for use of the request.
Chairman, I ask unanimous consent to place in the record a statement by our colleague Doris Matsui in support of the bills.
Without objection, so ordered. I have someone monitoring the floor with the number of minutes and members not voting, so I'll keep you updated on that. But this time I'll introduce our panel. We have one panel today, and thank you all for coming. I'll introduce you in the order of your presentations and ask if you can abbreviate them somewhat. At some point, if we don't get through them, we'll have to go to the floor and return to hear the rest. But first, Dr. Jeff Chell, Chief Executive Officer, National Marrow Donor Program, Dr. Joanne Kurtzberg, President, Cord Blood Association, Dr. Patty Freemeyer, Martin, PhD, Director of Audiology and Speech Language Pathology, Arkansas Children's Hospital, Dr. Stephen Patrick, Assistant Professor, Pediatrics, Health Policy Department, Pediatrics, Vanderbilt University School of Medicine, and finally, Dr. Mishka Turplin, Medical Director of Behavioral Health System of Baltimore. Thank you for coming today. Your opening statements, written opening statements, will be made a part of the record, as will all members' written opening statements, as usual. You'll be given 5 minutes to make your summary. If you can abbreviate that, we'd appreciate it. So at this point, the chair recognizes Dr. Chell for 5 minutes.
Good morning, Mr. Chairman and other distinguished members of the committee. Thank you so much for inviting us today. As you've heard, I serve as the CEO of the National Marrow Donor Program and Be the Match. We have operated the C.W. Bill Young Cell Transplantation Program since its inception, and that includes a single point of access, the Office of Patient Advocacy, the Bone Marrow Coordinating Center, as well as the Cord Blood Coordinating Center. And with the Medical College of Wisconsin, we hold the contract for the Stem Cell Therapeutics Outcome Database through our research entity, the CIBMTR. I serve as Executive Director of that entity. I'd like to thank you all and members of the subcommittee for inviting us to speak on behalf of our 565 network partners all over the world. And at the NMDP, we deeply appreciate your support of helping us fight blood cancers through transplantation, often the only potential cure for these deadly diseases. I'd also like to thank Representatives Chris Smith, Doris Matsui, David Jolly, and Shaka Fatah for their leadership in introducing H.R. 2820. As I testify before you today, I'm reminded of a hearing in 1987. On that day, the late Congressman Bill Young called on Congress to establish the National Registry, where children and adults with leukemia and other fatal blood disorders could find a donor. Congress heard that call at that point and established the National Registry. Congressman Young's vision was inspired by a child, an 11-year-old Brandy Bly, who was fighting leukemia. No one in her family was a suitable match, and without access to a transplant, she would not survive. At that time, there was no registry available. And it was a simple statement by her physician that really stimulated Congressman Young to take action. And he said, wouldn't it be great if there were a registry of donors that we could tap in to help save a life like this? And that really became the basis of our national registry. Since that hearing in '87, we've made great progress. The NMDP is now the global leader in providing cellular therapy, which is often the only treatment available that can cure some of these life-threatening blood disorders and other significant diseases like sickle cell disease. We also educate healthcare professionals, conduct research, and offer support and education in multiple languages to help patients lead healthy lives after transplant. Today, children like Brandy have a much better chance for a life-saving transplant. We've been honored to serve as the steward of this critical resource for the last 28 years. During that time, the growth of transplant has increased significantly, and even since 2005, transplants overall have grown 200%, and for minorities, it's grown 250%. We now have over 12 million donors in our registry and over 200,000 cord blood units, but we partner with 66 registries all over the world to provide a total of 25 million donors and over 600,000 units of cord blood. And it's as easy to find a donor and make that transplant happen if that donor were halfway across the world or across the street. Outcomes for transplant have also improved, as well as the number of transplants. So the one-year survival has gone from 40% to over 70% in the last 10 years. But we're especially proud, if we could show the first slide, of our work fighting diseases afflicting children. In 2014, we facilitated 1,200 unrelated transplants for patients 18 years and older. And the first slide shows how important the source, not only bone marrow, but also umbilical cord blood, is in fighting transplants. Dr. Kurtzberg and other pioneers in this field introduced cord blood in the late 90s, and those truly are helping patients that we would have otherwise not been able to help. But your ongoing commitment has made these advances possible and turned the tragic loss of Brandy into hopes for tens of thousands of Americans. One of those is Hadley Mercer. She was just 6 months old when she was diagnosed with acute myeloid leukemia. After 2 rounds of chemotherapy, her parents and physicians agreed that a bone marrow transplant was likely her only chance as well as her best chance of survival. We found a perfect match for him, a young man in his 20s. Now almost 2 years old, she is going to have a normal and healthy life because of her donor angel. She is alive because of your continued support of the C.W. Bill Young Cell Transplantation Program. The NMDP has never forgotten the importance of that physician's simple statement that inspired Congressman Young, and every day we are inspired by people who we meet, young and old, who are seeking to find that match. If we could show the next slide, it shows us that even though we've made tremendous progress, we're meeting less than half the need of the pediatric population. And then the slide, you can show the lighter colored areas are areas where we're only meeting 25% or more of the total need. And as we get darker colors, you can see that there's more and more. So there's many, many more children we can help. So thank you very much for your time and attention.
Chair, thanks the gentleman, and we are out of time on votes for the floor. We'll look, find out how many people haven't voted, but at this point, Chair recognizes Dr. Kurtzberg, 5 minutes for opening statement.
I think you have to turn your mic on.
Poke the, yeah.
There we go. Mr. Chairman, Ranking Member Green, and members of the subcommittee, thank you for inviting me to discuss H.R. 2820, the Stem Cell Therapeutics and Research Reauthorization Act of 2015. My name is Joanne Kurtzberg, and I'm the president of the Cord Blood Association, a pediatric transplanter, and the founder and director of the Carolinas Cord Blood Bank, which is a public cord blood bank at Duke. I want to thank both Congressman Chris Smith and Congresswoman Doris Matsui for their leadership on the introduction of this legislation. I also want to acknowledge the subcommittee's bipartisan commitment to the creation and support of the NCBI, or National Cord Blood Inventory, a public cord blood banking network, which we began when this bill was introduced in 2005. I'm talking about a network of banks that save cord blood, which is the baby's blood remaining in the placenta or after birth, after the baby's born. In the past, this cord blood was discarded as medical waste, so it's never been a controversial source of stem cells. Cord blood contains stem and progenitor cells of the blood and other tissues, and it can be collected without harming the mother or the baby and banked for future use. And I put a picture up there of just what the bag looks like that we save cord blood in. We save it in less than an ounce of fluid in 2 compartments with little pigtails so we can test it later and make sure it's appropriate for a patient for transplant. If I could have the next slide, it shows you a picture of the very first recipient of cord blood transplant in the world, who was a little boy from North Carolina with a fatal disease called Fanconi anemia. His sister was a match and not affected, and when he was 5 years old, he went to France for this transplant. And on the right, you can see him 27 years later, doing well, happy, healthy, working, married adult with me. He reached the benchmark of being taller than me, which is what many of my patients like to do post-transplant. But most importantly, he is fully engrafted with his baby sister's cells, and that proves that cord blood contains stem cells of the blood. Next slide. Briefly, after that transplant, unrelated donor cord blood banks were established, first at the New York Blood Center, later through support from Congress to establish at NHLBI the Cobalt program at Duke and 2 other sites. And as you know, the first legislation was passed in 2005, establishing the National Cord Blood Inventory as part of the C.W. Bill Young Cell Transplantation Program. This stem cell source is unique because FDA has issued guidance to license cord blood, and there are now 5 licensed cord blood banks in the United States. In 2014, we also created the Cord Blood Association to represent both public and private cord blood banks and the cord blood community. Next slide, you can see just some milestones in cord blood transplantation. It's been pioneered in children with inherited metabolic diseases. It's been used with 2 cord blood or double cord blood transplantation, the University of Minnesota. There have been over 35,000 cord blood transplants performed worldwide, and 160 banks established worldwide since it started. This just shows you, next slide, some of the research that's going on. So we now have ways to expand cord blood in the red line, ex vivo, so that patients engraft in 6 to 10 days instead of 20 to 30 days. And if you go to the next slide, you'll see some just facts about the NCBI. There are 13 members, 5 licensed banks, not all of the money appropriated has actually been, or authorized has been appropriated over the past 10 years, but with the funding we've had, 90,000 high-quality, diverse cord blood units have been stored. The next slide shows you a kit that we can send out to moms who want to donate anywhere in the country, so their cord blood unit can be stored in the national inventory. Next slide shows you just an example of a little boy with Hurler syndrome. This is a fatal disease where children die by age 5, but with a cord blood transplant, you can see on the right, this child is a healthy adolescent with normal intelligence, and many children with these kind of diseases have been helped. The next slide lists some of the exciting regenerative medicine trials that are emerging for uses of cord blood beyond treating patients with leukemia and other diseases, and that includes autism, hearing loss, stroke, and cerebral palsy. Next slide shows you some data showing that babies with birth asphyxia have been, had their outcomes improved when they receive a cord blood infusion in the first 2 days of life. The next slide shows you our data from Duke showing that a cord blood infusion can actually help children with cerebral palsy regain function and regain normal performance. And the next slide shows you just how the brain can, in the lower left, actually form connections after a cord blood infusion. I thank you for your attention and for your support, and we'll be able to entertain questions later.
Chair, thanks to the gentlelady. And I apologize for the interruption here, but we must now go to the floor to vote. We're going to vote for 3 bills, and then we'll recess for that and come back immediately for the rest of the hearing. So without objection, the subcommittee stands in recess.
Yeah, I know.
I didn't even notice it, my God.
All right, the time for our recess having expired, we'll reconvene the subcommittee, and we're now ready for Dr. Martin. You're recognized for 5 minutes for your opening statement.
Thank you. Good morning, Mr. Chairman and members of the committee. I want to express ashes and my appreciation to Congressman Guthrie and Congressman Capps for their leadership in introducing H.R. 1344, the reauthorization of the Early Hearing and Detection Intervention Act for Children. This important bill provides assistance to states in identifying hearing loss in infants and young children and places an emphasis on ensuring that those identified with hearing loss receive appropriate intervention. Hearing loss is the most commonly occurring condition that newborns are screened for. 3 babies per thousand are born with hearing loss, and this number almost triples by the time children enter kindergarten. When hearing loss is detected early, children can learn sign language, be fit with hearing aids or cochlear implants, and/or receive early intervention services that enable them to achieve on par with their hearing peers. If it's not detected early, it can be devastating to children's academic and psychosocial development. There's now abundant scientific evidence that the brain develops in response to early visual and/or auditory stimulation, which is critical for children with hearing loss. Almost 30 years ago, a report commissioned by Congress showed that the average deaf child at that time had a 4th grade reading level when they were old enough to graduate from high school, in large part due to the fact that these children were not identified until they were 2.5 to 3 years old. Since newborn hearing screening has been implemented, we've seen the average age of identification drop to 2 to 3 months. More importantly, deaf children who are diagnosed early and receive appropriate early intervention often achieve on the same level with their hearing peers by the time they reach 1st grade. H.R. 1344 is the reauthorization of a very successful program which has been in place for 15 years. Because of this initiative called EDDI, 98% of babies are now screened for hearing loss before they're discharged from the hospital. Most of these babies go home to families where it never even occurred to their parents to wonder if they could hear them sing or whisper or coo, "Mommy loves you," or "Daddy's big boy." Early screening allows those infants who do not need assistance to be connected with services, or who need assistance to be connected with services, to learn to communicate with their families using sign language and/or hearing technology, and start on the path to prepare them for school readiness. Of babies who need follow-up, we know that 95% of those are born to hearing parents, often with little or no exposure to individuals who are deaf or hard of hearing. They find themselves in a situation that was unanticipated and for which their roadmap on parenting and all their how-to guides may not really apply. A great resource for many of these parents is having access to adults who are deaf or hard of hearing or other forms of parent-to-parent support, family-to-family support as stipulated in this bill. There's much to be proud about this previous legislation that is captured in the reauthorization. The EDDI program has enabled unprecedented collaboration between public and private agencies and across all levels of government. The EDDI program is often cited as a model of how government at different levels and private and public entities should and can work together. The reauthorization continues to emphasize the partnerships among HRSA, the CDC, and the NIH, and includes language for those agencies for further collaboration. I want to call your attention to a couple of sections in the bill. First, it focuses on continuing to provide limited federal support to programs already in place for infants. In the previous version of the bill, the focus was exclusively on babies. This bill reauthorizes services for babies and extends it to young children. This is critical because now we know that by the time children are 5 years of age, we will almost triple the number of children who have hearing loss. And we need to intervene with this group early so that they're ready to learn when they hit school age. Another important aspect is the focus on families being involved and empowered in the process for their children in a timely way. So engaging and enabling these families is not just desirable but critical. Family involvement is described as the tipping point for children having full access to language, whether it's visual, spoken, or a combination of both. And involvement of families is described as family-to-family support and from a variety of professionals, including deaf and hard of hearing consumers in this bill. It's about more than just screening for hearing loss. We do screening really well, but there's work to be done on getting appropriate services for many infants and young children. We have the basics in place, but systems to ensure that infants with hearing loss receive the appropriate follow-up for diagnosis, for medical care, and early intervention services from providers that have the knowledge and skills to help them communicate with their families needs to be refined and improved. Because of previous funding for the EDDI programs, loss to follow-up has been reduced by half over the last 10 years, but there's much more work to be done. Thank you.
Chair thanks gentlelady, and now recognizes Dr. Patrick. 5 minutes for your opening statement.
Chairman Pitts, Ranking Member Green, and honorable members of the committee. My name is Stephen Patrick. I'm a neonatologist and researcher at Vanderbilt University School of Medicine. It's a privilege to speak with you today about the rising number of infants being born diagnosed with drug withdrawal in the United States. The bill before you, H.R. 1462, the Protecting Our Infants Act of 2015, makes positive steps to improve the health of women and infants impacted by opioid use and misuse. A few months ago, I was caring for a 2-day-old baby in the neonatal intensive care unit at Vanderbilt Children's Hospital. At just 48 hours of life, the infant became fussy and jittery. Over the next 24 hours, the infant continued to worsen with diarrhea, sneezing, increased fussiness. Each of these signs are classic for drug withdrawal. However, his mother denied use of any drugs that may cause withdrawal until the baby's drug screen came back positive for prescription opioids. Once I informed the mother of the baby's drug screen, she reluctantly admitted that she had been using pain pills without a prescription. The baby remained in the hospital for a bit, undergoing treatment. And as I reflected on this case, I began to wonder, what if the infant had been discharged at home at the typical 24 hours of life, only to have drug withdrawal at home? Would he have been brought back to the hospital critically ill? And what systems may help his mother be more knowledgeable and forthcoming about her drug use? And how do we connect her with drug treatment, particularly during pregnancy? This situation, unfortunately, is increasingly common. Neonatal abstinence syndrome is a drug withdrawal syndrome that infants exposed to opioids experience shortly after birth. Opioids pass from the mother through the placenta to the fetus. At the time of birth, when the supply is stopped, the infant's at risk of developing drug withdrawal within the first few days of life. Infants with neonatal abstinence syndrome have difficulty feeding and are more likely to have breathing problems, tremors, increased muscle tone, fever, difficulty sleeping, and inconsolability. Severe neonatal abstinence syndrome requires treatment with an opioid, like morphine or methadone, and an average hospital stay of about 3 weeks. Watching an infant have drug withdrawal is distressing for doctors, nurses, and for parents. According to the Centers for Disease Control and Prevention, the number of prescription opioids used in the United States quadrupled over the last decade. And by 2012, there were 259 million prescriptions written for an opioid, more than one for every American adult. This rapid increase in opioid use and misuse impacted nearly every population in the United States, including women of childbearing age and pregnant women. In a study our group published in May, using data from the Tennessee Medicaid program, we found that of 110,000 pregnancies in a 3-year period, nearly 30% filled a prescription for an opioid pain reliever during pregnancy. Throughout the country, as prescription opioid use grew, so did the incidence of neonatal abstinence syndrome. Using billing data from the nation's hospitals, our research team conducted a series of studies to determine national rates of neonatal abstinence syndrome. From 2000 to 2012, the number of infants diagnosed with the syndrome grew nearly 5-fold. By 2012, one infant was born every 25 minutes on average in the United States with neonatal abstinence syndrome, accounting for an estimated $1.5 billion in healthcare expenditures, 80% of which are paid for by Medicaid. The scope of the problem is staggering in some communities. For example, some areas of my home state, Tennessee, report that 1 in 20 infants born in their community have neonatal abstinence syndrome. And at some NICUs, nearly 50% of their total annual hospital days are dedicated to treating this one condition. This rapid increase has largely caught communities and providers off guard. Today, there are no well-researched standard treatment protocols for infants with NAS, and as a result, treatment and clinical outcomes vary widely throughout hospitals in the United States. Addressing the complexity of perinatal opioid use and neonatal abstinence syndrome requires a thoughtful public health approach. Our goal should be to promote healthy mothers and infants by supporting prevention and recovery, and this must begin with primary prevention. Engaging public health measures to prevent opioid misuse even before pregnancy, including bolstering prescription drug monitoring programs, improving access to contraception, ensuring opioid prescribing is necessary and appropriate, especially among pregnant women. And secondary prevention, improving screening for drug use in pregnancy, and ensuring that drug treatment is available when it's needed, and that it includes medication-assisted treatment when appropriate. Treatment should be comprehensive, gender-specific, and inclusive of obstetric care. And tertiary prevention, improving identification and treatment of infants suffering with neonatal abstinence syndrome, and working to improve post-discharge outcomes. Mothers and infants impacted by the prescription opioid and heroin epidemics are in desperate need of a public health approach to address this problem. We cannot wait any longer to respond, and the status quo is simply unacceptable. The Protecting Our Infants Act takes the necessary and important steps forward to improving research and service care delivery. For the patient I described in my introduction, and for the thousands like him, we need the tools to learn how to treat him better, and perhaps even more importantly, to prevent him from being there in the first place. As a neonatologist and researcher, I applaud the bill's authors and the committee's interest in this critical public health problem and this issue that affects so many vulnerable mothers and infants in the U.S. today. Mr. Chairman, I thank you for the opportunity to speak today, and I look forward to your questions.
Chair, thanks, gentlemen. Now recognize Dr. Turplin for 5 minutes for an opening statement.
Good morning, Chairman Pitts, Ranking Member Green, and distinguished members of the subcommittee, and thank you for having me here today. My name is Mishka Turplin, and I am an OBGYN and addiction medicine specialist and the medical director of Behavioral Health System Baltimore. I'm pleased to testify on behalf of the American Congress of Obstetricians and Gynecologists in support of H.R. 1462, the Protecting Our Infants Act. I would like to thank Representatives Catherine Clark and Steve Stivers for their leadership in introducing this legislation and the 8 co-sponsors on the Health Subcommittee, and I urge the committee to act swiftly in reporting out this bill. H.R. 1462 represents a bipartisan, bicameral effort to address the critical problem of opioid addiction and neonatal abstinence syndrome facing pregnant women from all socioeconomic backgrounds. NAS refers to medical issues associated with drug withdrawal in newborns following prenatal opioid exposure and is expected and treatable, with no long-term negative outcomes documented in the literature. While I want to stress the importance of the mother-infant dyad, my testimony will focus primarily on the woman and how passage and implementation of this bill would improve access to quality treatment and care for this population. Specifically, the bill would commence 3 important initiatives that address the following. 1, prevention and treatment of prenatal opioid use disorders. Preventing inappropriate opioid use among pregnant women and women of childbearing age is crucial. Quality preconception care and family planning optimize a woman's health and knowledge before conceiving a pregnancy, improving the likelihood of having a healthy pregnancy and a healthy baby. Among women with opioid addiction, almost 90% of their pregnancies are unplanned. All pregnant women are concerned for the health of their baby-to-be and are motivated to change unhealthy behaviors. Most pregnant women who use substances, including opioids, quit or cut back. Those who cannot stop using, by definition, meet criteria for having a substance use disorder. In other words, continued use in pregnancy is pathognomonic for addiction, which is a chronic relapsing brain disease. When treating pregnant women with opioid addiction, withdrawal or detoxification are rarely clinically appropriate. Detox results in relapse, and any abrupt discontinuation of opioids can result in preterm labor, fetal distress, or fetal demise. Safe prescribing during pregnancy includes opioid-based medications such as methadone or buprenorphine, which are standard of care for pregnant women with opioid addiction. However, pregnant women continue to face access issues, and most do not receive opioid agonist therapy. Denying pregnant women evidence-based treatment in order to prevent NAS is discriminatory. Additionally, opioid medication should be accurately labeled to ensure appropriate access to medication for women who are addicted and for whom the alternatives, such as heroin or withdrawal during pregnancy, are much more dangerous. Specifically, the FDA boxed warning related to pregnancy should be removed or updated to remove the inaccurate information linking opioid use during pregnancy with, quote, life-threatening neonatal opioid withdrawal syndrome, a claim with no scientific evidence. Number 2, gaps in research and programming. Additional research is needed on effective and non-addictive pain treatment, and any such research should include women of childbearing age and pregnant women. However, it is important to note that medically appropriate opioid use in pregnancy is not uncommon, and opioids are often the safest and most appropriate treatment for a variety of medical conditions and severe pain during pregnancy. Pregnant women with substance use disorders need access to comprehensive services, including prenatal care, drug treatment, and social support. Punishing pregnant women with substance use disorders by targeting them for criminal prosecution or forced treatment is inappropriate and will drive women away from care. Innovative treatment models are needed and should be tailored to pregnant or parenting women and should provide priority access. Number 3, improved data collection and surveillance. Opioid addiction has become more widespread geographically and demographically. In communities with high opioid prescription and addiction rates, there will be higher rates of pregnant women with opioid addiction and subsequent NAS. Access to national and state-specific NAS data would enable trend analysis and foster greater sharing of best practices and treatment strategies. Improved data collection would also help us better track and understand the long-term outcomes of infants with NAS. For those purposes, data endpoints need to be of both clinical and sociological significance. Thank you for the opportunity to testify at today's hearing. The committee's attention to and interest in reducing maternal opioid addiction and NAS are crucial, and the Protecting Our Infants Act represents a positive step forward in addressing this growing issue. I welcome your questions. Thank you.
Chair, thanks, gentlemen. That concludes the opening statements of our panel. We'll now begin questioning. I'll recognize myself 5 minutes for that purpose. Dr. Chell, we'll start with you. In what patient population do you see the number of transplants rising the fastest? If you can give us sort of a...
Yes, the group that's rising the most quickly is the elderly population, the senior population, and that's growing by double digits every year. And the reason for that is the medical conditions for which transplant is often the only cure tend to occur in older populations, diseases like acute myeloid leukemia, myelodysplastic syndrome, myelofibrosis, and others.
Dr. Kurtzberg, while the cord blood and the bone marrow donor programs have enjoyed great success over the past 10 years, what, if any, are the barriers you face to realizing the full potential of these programs?
There are two major barriers I would cite. The first is that cord blood grows slower than bone marrow when you first give it for a transplant, and so there's a big need for more research to develop ways to expand cord blood in the laboratory before it's infused. And I showed one slide showing that there's promising work being done in that area. The second is that the cost of a cord blood transplant, and that's for procuring the donor and also taking care of the patient, is higher than some other types of transplantation. And part of that is due to the fact that with licensure of cord blood, the costs of manufacturing have gone up, while the market-bearing price for reimbursement cannot change, because really it's already too expensive to have a transplant. So we're really struggling for cord blood to be able to be subsidized through programs like this, so that the patient can afford to use the donor.
Thank you, Dr. Martin. Can you elaborate on the importance of medical intervention for and follow-up with medical services for deaf individuals? Why is a public health-based approach important at this time?
Children with hearing loss need follow-up for medical intervention, because sometimes hearing loss will be coexisting with other conditions. We want these children to be evaluated for what other coexisting morbidities might occur with hearing loss. What we do know is about a third of children with hearing loss also have another disability as well, and so that medical piece is really critical for them. It makes it a very important public health program. The American Speech and Hearing Association, the National Center for Hearing Assessment and Management, the American Academy of Pediatrics, American Academy of Otolaryngology have all worked really well on this to ensure that these children get the type of medical care that they need to assist them in having improved outcomes.
Thank you, Dr. Patrick. You have performed extensive research on neonatal abstinence syndrome. In your written testimony, you state that Medicaid spent $1.2 billion for NAS hospitalizations in 2012. In February of 2015, the GAO released a report that showed gaps in research funded by the federal government in this area. Where should future research focused to close those gaps?
Well, we have research gaps throughout the continuum of neonatal abstinence syndrome. We need better measures to identify patients at risk of drug withdrawal. We need better systems to diagnose drug withdrawal. The current way we diagnose drug withdrawal is if we have an infant that we know has been exposed to an opioid, so we have to know that first. And then we score them on a system that can be pretty subjective. Basically, it's an observation of the infant, and we go through a checklist of what they look like. That was developed decades ago. We need better systems that are more objective and perhaps use technology to aid in that. And we also don't have great mechanisms to understand what is the most effective way to treat these infants. How can we be most efficient? How can we ensure that we can keep mom and baby together when we can? There's a lot that we have to learn, and I think there are gaps throughout the continuum of our treatment of infants.
Thank you. Dr. Turpin, can you provide more background on the statement in your testimony that the FDA boxed warning related to pregnancy is incorrect and is not validated with scientific evidence? What problems has this caused? To your knowledge, is the FDA in the process of addressing this?
So the statement on the box is that use of methadone can cause life-threatening neonatal opioid withdrawal syndrome. The likelihood of death from NAS is no different from the likelihood of death for other infants born at matched gestational age. So it does not contribute an excess mortality risk to newborns, neonatal abstinence syndrome. So that's scientifically inaccurate. The FDA has convened a panel to discuss the labeling of this medication that both ACOG and the American Society of Addiction Medicine testified at a couple of weeks ago, so they are working towards that.
All right, thank you. My time's expired. Chair recognizes the ranking member, Mr. Green, 5 minutes for his questions.
Thank you, Mr. Chairman. Again, I'd like to thank our witnesses for being here today and also for your understanding of our unusual schedules to run vote on the floor. I'd like to ask about the treatment that's available to women with opioid use disorders during pregnancy. The GAO report released earlier this year cited numerous gaps in the treatment of NAS as well as into the treatment of women with opioid use disorders. One of the major barriers the GAO identified was the stigma and criminalization of pregnant women who struggle with substance use during pregnancy. For instance, some state laws require healthcare providers to report substance use during pregnancy to state or local law enforcement officials. One state, Tennessee, defines drug use during pregnancy as criminal assault. According to Guttmacher Institute, 18 other states treat substance abuse during pregnancy as child abuse under civil child welfare statutes. Dr. Turpin, what is the impact of such laws on the incentive for pregnant women to seek treatment for addiction as well as prenatal care?
Thank you very much for asking that question. Criminalizing or punishing pregnant women for substance use during pregnancy is a disincentive for them to seek or prenatal care or seek substance treatment services or to continue with them. I know anecdotally from colleagues of mine who practice in Tennessee, which is the only state that has explicitly criminalized substance use during pregnancy, that they're seeing women who are entering prenatal care late, going across state lines to delivering at home. One colleague of mine had a patient who delivered at home out of concern for being reported. She started bleeding and the infant had something going on. They went to the emergency room, and at that point in time, she was arrested. So her actual concern with avoiding health care because of a fear of being caught up in the criminal justice system was realized.
How do these, Dr. Patrick, how do these laws impact the diagnosis of treatment of NAS?
Well, I think in part, beginning with women avoid care. They're more likely to not seek care in a hospital, and that alone is a disincentive. It creates a barrier to improving infant outcomes. The other piece is that we have to know about the exposure. If there aren't systems that allow women to be forthcoming about their drug use and seek treatment, then we don't know about the exposure. So the infant that I described in my introduction, if we didn't know about it, and that infant didn't have a rapid weight loss within the first 2 days of life, that infant would have been discharged home. Because we wouldn't have known about it, having to withdraw at home and potentially having complications at home, including severe dehydration. So I think that's why these systems, public health systems, a public health approach is much preferred to a criminal justice approach.
Well, and I understand legislatures and people being shocked by a mother having a child that's a user. What would you recommend as effective alternatives to address the issue of the prenatal drug use and improve health outcomes for both the mother and the child?
Well, I think it begins with a lot of what the bill is doing, to begin to get people at the table to understand what are the knowledge gaps, how do we coordinate things better. It begins with a public health approach to improving access to treatments and to understanding how we curb opioid use and misuse overall, even before pregnancy. I think the easiest way to prevent an infant having drug withdrawal in my unit is to prevent opioid misuse even before pregnancy. So I think those public health measures are critical.
Okay. Dr. Turpin, you identify a number of additional treatment gaps for pregnant women with substance use disorders. You mentioned, for instance, the lack of access to medication-assisted therapy for pregnant women. Dr. Turpin, is medication-assisted treatment the standard care for pregnant women with opioid use disorders?
Yes, and not just for pregnant women, it would be for men and non-pregnant women. Medication-assisted treatment would be the standard of care for opioid use disorders.
What are the barriers to women accessing medication-assisted therapy, and what can the federal government do to address these barriers?
There seems to be, we did some research on this, about only 40% of pregnant women who are admitted into drug treatment for an opioid use disorder receive medication-assisted treatment in the United States. Some of that has to do with the context of treatment. There are many abstinence-only treatment modalities and treatment programs, so they're not getting access to it in the treatment context. I know in my state of Maryland, I hear a lot of questions from providers throughout the state. There are large counties in Maryland where there's not a single buprenorphine provider who will take a pregnant woman. So I'm in the process of going around the state and educating the substance treatment providers on how to care for the pregnant women. And one of the concerns that people have is a misperception of perhaps a medical legal liability, lack of knowledge in how to care for the pregnant woman, and oftentimes a lack of good integrated care between the prenatal care providers and the addiction treatment providers.
Okay, thank you, Mr. Chairman. I know I'm out of time.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the Subcommittee, Mr. Guthrie, 5 minutes for questions.
Thank you very much. Before I get to my questions, Dr. Patrick, I'm from Bowling Green, Kentucky, so a lot of people have been to the NICU at Vanderbilt and used it, and it's been a blessing to have such a world-class, that close. We do have a NICU in our area. My cousin, Scott Guthrie, I don't know if you ever practiced with him. He's from Jackson, Tennessee, but does cover the NICU in Bowling Green.
I know him, yes.
Yeah, so thanks for what you do. So I want to talk to Dr. Martin. I'm the sponsor of the early hearing detection bill, so I want to focus on that. Universal newborn screenings work very well, the newborn side. Could you help the committee understand why it's important to expand to early childhood screening? You know, I can see where a parent would not understand if their newborn wasn't listening, because particularly if it's your first one, you're not sure exactly what they're supposed to communicate. But wouldn't a parent know if a child was 3 or 4 if they couldn't hear?
Well, one of the things that we see is that children who have what's called late onset hearing loss like that were born with normal hearing, then acquire hearing loss in the first 3 to 5 years of life, that really they're pretty good at hiding out from their parents. So they read lots of visual cues that go on in their environment. There's lots of redundancy in how we tell kids to do things at that age. And parents want their kids to be typically developing. So it really flies under the radar a lot with that age child. We know from the statistics that we will almost triple the number of kids who are identified. So if it's 3 per 1,000 at birth, we're going to have 2 to 3 times that number of kids who enter kindergarten. And even a mild, moderate to severe hearing loss in a child can be missed until they enter school age. And we want to intervene with them early. We've got great programs in place that can help them be ready to learn when they enter school. So it's important to expand it.
Okay, thank you. Also, there seems to be a sense of urgency about deciding how to communicate with your child once they're diagnosed with a hearing issue, and some strong opinions about whether families should use American Sign Language or spoken language. How does the early detection bill address this issue?
One of the important decisions that families have to make when their child is diagnosed with hearing loss is how they want to communicate with them. So they're making decisions about technology use, they're making decisions about the best way to communicate with their child or not. One of the stipulations in this bill is that families be given all the information about all the options that are available to them. So what we want for families is for them to have the opportunity of informed choice. So we want to give them the information and help them weigh that in their family situation, with their family dynamics, what their desired outcomes long-term are for their child, with their culture and traditions and beliefs in their family, and make a decision about what sort of communication mode they choose. So it might be ASL, American Sign Language, it might be listening and spoken language, it might be some combination of both. The good news is that there's not a right choice. The right choice is the choice that a family makes for their child, and we know that the Eddie bill has provisions in it that help us engage and equip families to make those decisions and to follow through with whatever decision that they make.
Well, thanks. And I was involved in creating and expanding a program. Actually, it was the governor's initiative. I was involved in getting it passed when I was in the state legislature. And so a lot of states are doing this. What's important for federal funding? What's the role of the federal government in this?
Well, the federal funding really primes the pump for this. It's a great example of the federal government seeing something that could take place and really be beneficial to families and to children and stepping in and setting that program up. And so basically it's money that primes the pump for states to do what needs to be done to identify these children and get them enrolled in services and helps them continue that process. So the states are all implementing it in different ways, in lots of different successful ways. The federal money helps us be able to share information back and forth and to be able to move towards best practice and evidence-based practice as we move forward in helping these kids attain their full potential.
Well, thank you very much. And when I was involved, I did research in the bill, and I remember talking to a researcher at Vanderbilt. That's where I went down to really understand what was moving forward and whether to be for it or not. How much government do you get involved in? And they told that if a newborn child, even if it was healthy, put them in a room where they couldn't hear, by the time they were 3, they would never be able to develop the proper speech pattern. So what if a child could be corrected or get on the right path in the earliest state? And the other thing we did was eye screening. So the reason I bring that up, because this is a hearing, is they said the normal pediatric screening would catch you going into kindergarten almost all the time, except for about 1 or 2%. And so do you increase this program for 1 or 2%? Well, if you're one of those parents, you do it. And it turned out when we passed the bill, my child had to go to an optometrist before kindergarten at 5, and he was one of the 1 or 2%. So these are important programs, and I'm pleased to be involved and pleased to work with Congresswoman Capps on this. And thank you for coming from Arkansas. Appreciate it.
Thank you very much.
Yield back.
Chair, thanks, gentlemen. Now I recognize the gentleman from Oregon, Mr. Schrader. 5 minutes for questions.
No questions, Mr. Chairman.
All right, we'll go to Mr. Kennedy.
Thank you, Mr. Chairman. I want to thank the witnesses for attending today and your testimony, and I really want to recognize the chairman for calling a very important hearing. I'm going to focus my comments a bit on the opioid epidemic, which has been devastating for parts of Massachusetts and for expanding communities across our country. One thing that I know the entire room can agree on is with regards to the opioid crisis that is devastating in its reach. As we've heard even from your testimony so far this morning, it does not discriminate, not by race, gender, age, demographics, income, or any other metric. The breadth and depth of this epidemic is particularly painful when it comes to its youngest victims, newborns, and the rise of neonatal abstinence syndrome, NAS. In the United States, the rate of opiate-dependent births has nearly tripled since 2009. In my home state in Massachusetts, the Department of Children and Families received 2,376 reports of substance abuse-exposed newborns between March of 2014 and March of 2015. In Tennessee, a recent study of the state's Medicaid program found that over a quarter of all women in the program were prescribed opioid pain relievers during pregnancy. Of the infants born there with NAS, 65% were born to mothers who were legally prescribed opioids. These statistics make it clear. We are falling far short in our efforts to protect the youngest among us from an epidemic, and we are failing to provide reliable, appropriate care to pregnant women. We need to start researching today to protect our children tomorrow. I want to recognize and congratulate and celebrate the efforts of our colleagues, Congresswoman Catherine Clark from Massachusetts and Congressman Steve Stivers, whose efforts will help address this dangerous failure to grasp the reach of NAS. And I thank them both for their leadership on a critical issue. With that said, I wanted to focus my first question to both Dr. Patrick and Dr. Triplin. Can you expand on the gaps in research in NAS, particularly around prevention and treatment? And what evidence-based medical guidance is currently available to doctors and nurses who treat mothers and newborns? I know you both touched on it a little bit in some of the questions, but I'd like to flesh it out a little bit more if you can.
Well, I think the gaps, we talked a little bit about some of the issues with diagnosis. We can go on throughout the spectrum and understanding how we send these kids home safely. We have infants with neonatal abstinence syndrome are about 2.5 times as likely to be readmitted to the hospital within 30 days after discharge. We really need systems, both service care delivery, as well as research into the best mechanisms to ease that transition home. It's a complicated time for families, and you can think about an infant who's already a bit more fussy than usual and how this can be a challenging time for families. And so part of it is supporting families in that transition, perhaps using things that we know work well with the evidence that exists for childhood, like home visitation programs. There really needs to be more targeted evidence towards this population, and perhaps using evidence that we've garnered from other places. And as far as prevention, I think the committee's work that the committee's been working on more broadly on the heroin and prescription drug epidemics, I think bolstering programs like prescription drug monitoring programs and targeting special populations, it's really important. And ensuring that they're well funded at the state level and perhaps even targeted towards special populations such as women of childbearing age.
Thank you. Doctor?
So I'm going to focus my comments more on women. Identifying women with substance use disorders at the time of labor and delivery is 9 months too late. So we need to be doing universal screening for substance use during prenatal care. And that should be done not just with toxicology testing, which is the most common way we test for things, with a urine test, which is not a test for a behavioral disorder that addiction is, but with an instrument, a validated instrument. And we actually need to have more validated, more good comparison between what's the right set of questions to ask. There is a CDC-funded study that I don't know if it started yet, but it just got approved to compare different screening instruments during pregnancy. So we will have better data for that in the future. Really, for me, the research question is one about implementation. We know what treatment modalities work. The issue is that women aren't getting access to them. And so it becomes not a hypothesis question of what is best practice per se, but how to deliver what we know to the population.
I got 25 seconds, Doctor. I want to push you a little bit. What's the barriers to access? What can we do to alleviate those?
I think there's a knowledge deficit. I think there's also a criminalizing of pregnant women for substance use disorders discourages adherence with treatment or accessing care, and so they're showing up on labor and delivery rather than during treatment or during pregnancy. And I think there's also some federal barriers in terms of dissemination of methadone, and also we don't have enough prescribers for buprenorphine in the United States.
Thank you both. I yield back. Thank you, Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Pennsylvania, Dr. Murphy, 5 minutes for question.
Thank you. I'll try and rush through these. First, Dr. Kurtzberg, as an experienced cord blood banker and cord blood transplanter, what's your definition of a high-quality cord blood unit?
That's a great question. So a high-quality cord blood unit needs to be sterile. It needs to be checked and incapable of transmitting genetic or infectious diseases. And most importantly, it needs to be potent. And potency can be measured by the number of cells that are in the unit. And we know number of cells.
So do you think the current HRSA contracting policies optimize the collection of high-quality cord blood units?
No, I think HRSA needs to help the banks to be incentivized to collect bigger units with more cells, and right now, their policy does not do that.
And you mentioned that among the potential uses for cord blood in regenerative medicine, you have initiated trials using cord blood to treat brain disorders, including autism. Could you please explain for the committee the current status of that project and insight you have about the future of that research?
Sure. So we think this research has enormous potential in autism, cerebral palsy, and other brain disorders in children that are probably acquired and not genetic. And in these cases, we've initiated studies predominantly funded through the Marcus Foundation or the Robertson Foundation, where we're looking at the role of cord blood infusions in those children. In autism, we've completed a 25-patient study for children ages 2 to 6, where we're looking at endpoints at 6 months and changes in symptoms of ASD. And we've shown that children who get a higher dose of cord blood cells, similar to the dose we would give a patient with leukemia or another malignant diagnosis, benefit and have improvement in the symptoms with decrease in autistic symptoms. We think, and we have evidence on MRI, that this is due to a normalization of the connectivity in the brain that's coming from signaling of the cord blood cells to cells in the child's brain, which helps repair these conduction pathways.
It's fascinating. I want to follow up with you in future questions, but let me ask Dr. Turplan and Dr. Patrick. I used to work at an NICU as a psychologist, would follow up children with developmental disorders. And I'd be correct in saying that maternal opiate use has some increased risk for developmental problems in a child, either directly or also related to such things as low birth weight, prematurity, decreased head circumference. Am I correct in that continuing to be a concern?
I'm happy to address that. I think the literature is difficult. There have been several studies demonstrating some issues with behavior, in particular some other issues when lazy eye strabismus has also been described. But one of the things that we need is more research to follow these infants long term.
Well, let me ask this too. It also concern increased risk for mortality if the physician is not aware of some of these problems during pregnancy and increased risk for fetal demise, et cetera. Am I correct with those? And I'm going to this question. I believe, Dr. Turpin, you mentioned one of the issues is information. I also chair the Oversight and Investigation Committee here, and many of the subcommittee, many of the colleagues have been part of that. We've looked at the issue of the concern for if someone is in treatment, those medical records are not there. So you can't find out. An OBGYN cannot find out because it's not in the record. And we've tried to address it. Should it be wholly within the record? Should it be under the patient's approval? This was based on 1970s law and regulations. Should the patient say, well, I'll put a 1-year waiver in to allow that information in there? We had testimony just a week ago where one of our former colleagues had said, you know, it's in the chart if he has an allergy to penicillin. Why can't it be in the chart that you have a reaction to opiates? Please don't prescribe it, or if I'm on there to know those things. I wonder if you can comment on this 42 CFR Part 2 thing that we're trying to deal with. Do you want access to those records?
Yeah, so the reason for that legislation was just because individuals with substance use disorders are prejudiced against in our society, and to protect
But I understand, but we've already established it's the neonates suffer.
Yeah, and so I think that the law, which had a reason in the past, actually does serve as a barrier to effective communication between parties. What I stressed when I talk about this is that there needs to be close collaboration between prenatal care providers and drug treatment providers, and that consent forms need to be signed to get around that, you know, so that information can be easily shared.
I just want to make sure we're not making behavioral medicine and physical medicine separate but equal.
Correct.
And if you can have toxic and higher mortality rates. We know the mortality rate has skyrocketed to 42,000 deaths from drug overdose last year. We know this is a huge problem with neonatal abstinence syndrome. I hope you'll respond more to this committee with your insights. I'd be fascinated by them to hear more, because we want to make sure that you as providers have the information you need to know when you're dealing with a baby what's the problem is, so you can deal with it effectively. Thank you very much. I yield back.
Chair, thanks, gentlemen. And now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. I think it's important to understand neonatal abstinence syndrome, or NAS, in the context of the public health challenge of the overprescribing of opioids, painkillers in the United States. Between 2000 and 2010, there was a 4-fold increase in the use of prescribed opioids for the treatment of pain. In 2012, healthcare providers wrote 259 million prescriptions for opioid painkillers, enough for every adult American to have a bottle of pills. So my questions are, Dr. Patrick, first, can you describe what has happened with the incidence of NAS in the past decade? In your opinion, is this phenomena tied to the issue of the overprescribing of opioid painkillers for pain?
Well, over the last decade, we know that neonatal abstinence syndrome has grown 5-fold. And by 2012, 1 infant was born every 25 minutes on average with the syndrome. When we look at specific studies, there's been several studies looking at what's happening in generally in prescribing. As you described, it's increased. But it's also increased among women of childbearing age as well as pregnant women over time. In a recent study we conducted in Tennessee, we looked specifically at opioid prescribing in pregnancy, and we found that nearly a third of pregnant women had an opioid pain reliever prescribed in pregnancy, and most of those, 96%, were short-acting opioids. So yes, I think there's compelling evidence that what we've seen in our neonatal intensive care units and in labor and delivery is a result of the broader prescription opioid epidemic, and it's the downstream effect that we're seeing negatively impact both women and infants.
I think I was going to ask some questions about the Tennessee Medicaid program, but I think you just answered them, so let me move on. I was surprised by the prevalence of opioid prescribing in pregnant women, it's eye-opening to say the least. And I think most of us associate NAS with illicit opioid use, including heroin. While it's certainly important to ensure that pregnant women have access to treatment for pain, it's also important for patients and providers to understand that medical use of opioids during pregnancy presents a risk of NAS. So do you think there needs to be more research conducted to inform us on when it is indicated to prescribe opioid painkillers during pregnancy?
So from my perspective as a neonatologist, yes, I think guidelines would be helpful. I think the nuance here is that we have in one population perhaps overprescribing, but we also have difficulty accessing medication-assisted treatment. So one thing that's important to know is that neonatal abstinence syndrome is not the worst complication of pregnancy. Preterm birth is. And in some women with substance use disorder, accessing medication-assisted treatment is vital. So we have this group of patients who have difficulty accessing medication-assisted treatment, and we have another group of patients who are likely being overprescribed opioid pain relievers, and another group of patients who are now using heroin. And so we need more research to understand this diverse population and how we improve outcomes based upon all of them. And I think that's why the goal needs to be overall to improve health for moms and babies, because they are tied so closely together.
Well, thanks. In your paper, you conclude, and I quote, "Prescription opioid use in pregnancy is common and strongly associated with neonatal complications." Could you just elaborate on that statement? In other words, what are the neonatal complications associated with NAS, and how are they linked to prescription opioid use during pregnancy?
Well, in that study, we looked at two different groups of people. We looked at, or three actually, where there were no opioids prescribed, where there were opioids prescribed but neonatal abstinence syndrome did not occur, and when neonatal abstinence syndrome occurred. For infants that were exposed to opioids and for infants with neonatal abstinence syndrome, they were more likely to be born preterm and low birth weight, more likely to have respiratory complications, have things like jaundice and feeding difficulty. That was much more common among those infants. And I think, again, that's why primary prevention aimed at both moms and babies is really where we should target.
All right. I want to thank you for your good work on this issue and for bringing much-needed public attention to the issue of NAS. I also wanted to thank Representatives Clark and Stivers for their work on Protecting Our Infants Act of 2015, which will hopefully focus our efforts to address NAS at the federal level. You're pretty fast in answering those questions so that we can get it within our 5 minutes. Thanks again.
I'm a fast talker. Thank you.
Chair, thanks. The gentleman now recognized, gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you very much, Mr. Chairman, and good morning to the distinguished panel. To Dr. Patrick, opiate abuse is a growing problem across the country, obviously, including in New Jersey. As a result, about 5 years ago, the Children's Specialized Hospital in New Jersey developed a neonatal withdrawal and rehabilitation program. When a baby is admitted, the hospital evaluates the child's symptoms using a 21-point checklist to determine how much medicine needs to be administered as the baby is weaned from its opiate, and a course of therapies designed to address many of the symptoms associated with neonatal abstinence syndrome, NAS, which has been discussed here this morning. For example, the hospital uses a special stimulation device on the baby's throat to teach the infant how to swallow. And the hospital also teaches the mother massage and calming techniques. Can you discuss the role that these types of rehabilitative therapies play in a child's recovery, and how will H.R. 1462 help to ensure that more children receive the comprehensive care that they receive at a wonderful hospital in New Jersey, the Children's Specialized Hospital?
Well, one of the things that we need to learn are more innovations, such as the things that you've described, where the literature may not be as robust. And so I think that's one thing that this bill provides. It outlines potential gaps. I think that's one of the targets and one of the potential ways that this bill helps. And what was the second part of your question?
I think you've answered it. We want to make sure that the bill is effective in developing techniques that will save the child's life. Are there similar programs? I'm sure that our program in New Jersey is not the only program that is trying to develop techniques in this area. Are there other programs across the nation, and what are some of the methods used in other programs?
Well, one of the most important things that we've seen grown up over the last several years are states building perinatal collaboratives focused on improving care to moms and babies, and nationally a group called the Vermont Oxford Network that we've been involved in that had
The Vermont Oxford.
Network, yes, sir.
That's Oxford in England, or?
It initially started that way, but this program involved at the start 200 NICUs, mostly in the U.S., but in a couple other countries, focused on improving the care to infants with neonatal abstinence syndrome. One of the first things that we needed to do was just standardize the care that occurred, because there's great variability from place to place. And hospitals like the hospital you describe, where they have a standard approach, we're focused on this one population, and we know that we treat this population the same way every time. That alone is associated with improved outcomes, and so that's part of where we've been working over the last several years. There are a few hospitals that have popped up, specifically focused. West Virginia is one specifically called Lily's Place, just to treat infants with neonatal abstinence syndrome. And those innovations to be able to allow rooming in where moms and babies stay together, because the NICU environment can be a chaotic environment where we have ventilators and all kinds of machinery, places where there can be a dark, quiet environment that where healing can occur as you've described.
Thank you. Is there anyone else on the panel who would like to comment? Very good. Mr. Chairman, I yield back 1.5 minutes.
Excellent. Thank you, Mr. Lance. Chair now recognizes Mr. Butterfield, 5 minutes for questions.
Thank you very much, Mr. Chairman, and thank all of the panelists for their willingness to testify today. I start off by apologizing for being late for the hearing. I've been trying to watch some of it on television while I've been trying to read the Supreme Court decision in the Burwell case a few moments ago, the 6-3 decision that for the second time affirms the Affordable Care Act, which was the historic law that we debated in this committee some years ago, and I was part of that debate, and our committee passed it. It passed the Congress, and now it's the law of the land, and it is working. And I just wanted to make that statement for the record. I realize that's not the subject of today's hearing, but I could not go back to my office without saying it. I'm not gloating, Mr. Chairman. I'm not gloating. I'm not gloating. I just want to reach across the aisle and say to my colleagues that the law is working, and let's make it work, and let's get health care to all Americans because they deserve it. I welcome the witnesses. I'm happy to recognize Dr. Joanne Kurtzberg, who is testifying today in her capacity as president of the Cord Blood Association. She is a professor of pediatrics and pathology at Duke University School of Medicine. Duke is one of the world's premier healthcare providers. That's undisputed. It educates and employs the world's top doctors and nurses and researchers, and I'm proud to represent Duke Med here in the Congress. Mr. Chairman, I support these 3 bills that we're discussing today. I encourage their expeditious consideration. As chairman of the Congressional Black Caucus, I know that many of the conditions which can be treated using cells from cord blood, like sickle cell anemia, disproportionately impact African Americans. And also as a member of Gallaudet University Board of Trustees, I care deeply about preventing hearing loss and supporting the deaf and hard of hearing community. Equally concerning is the marked increase in prescription opiate abuse among pregnant women and its impact on infants. Mr. Chairman, H.R. 1462 addresses this important issue and will identify ways to reduce neonatal abstinence syndrome. And so I appreciate the opportunity to discuss these very important topics. Now, Dr. Kurtzberg, it's no surprise, I'm going to go to you first, and with the time that I have, what are some of the diseases which impact African Americans disproportionately and are treatable by using cells from cord blood?
So the first disease we all would think of is sickle cell anemia, which can be cured with a hematopoietic stem cell transplant. And children and adults with sickle cell often have a hard time finding a match donor in their family or in the registry. Cord blood has the advantage of not having to be completely matched, and therefore it has become one of the optimal donor sources for patients with sickle cell disease.
Can you elaborate on the need for racially diverse units in the NCBI?
Yeah, so, you know, it's kind of a debate because we need big units. And biologically, patients with sickle cell patients who are African American have sticky cells, and their cells stick to the walls of their blood vessels. So when you do a blood test or a cord blood collection, you actually get a fewer number of cells per volume of blood than you would from a Caucasian. And so it makes it more challenging to collect high quality units from African American patients because you have to collect more to get big enough ones. Having said that, the match which is somewhat related to ancestry, will be better often if a patient receives a unit from someone of their own race. So really, the program is challenged to collect probably twice as many units from African American patients and donors in order to have a high-quality inventory for those patients. All in all, we need more African American donations and collections, and they will provide better matches to African American patients, but they have to also be targeted to be big enough to serve those patients well.
I'm also interested in the potential for new applications using cord blood and some of the cutting-edge breakthroughs that are being made in your field. Can you describe how your discovery of using unrelated cord blood for transplant benefits patients and how it could lead to future breakthroughs?
Well, so we've specifically studied at Duke the use of unrelated cord blood in children with certain genetic diseases that affect the brain. These are leukodystrophies like adrenal leukodystrophy, Krabbe disease, metachromatic leukodystrophy, and diseases like Hurler syndrome and many others. And from that work, we've also learned that cord blood cells go to the brain and facilitate repair of various abnormalities in the brain like demyelination or abnormal connections. And we are now using that observation to treat children with birth asphyxia, cerebral palsy, autism, and then adults with stroke. And I think we're just at the beginning of seeing the opportunity for cord blood to also treat patients with adult demyelinating diseases like MS or others.
Thank you very much. I yield back.
Chair thanks the gentleman and now recognizes gentlelady from North Carolina, Ms. Elmers. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel for being here today discussing this very important issue. Dr. Martin, I'm going to start with you. Can you talk about the early hearing detection and intervention program that has led to unprecedented collaboration between the public and private agencies across all levels of government, and what has made this model so successful?
I think that the previous legislation, and this is carried on in the reauthorization, it really outlines the role of HRSA, the role of CDC, the role of NIH, and we've just had great success in working together to improve outcomes for children. We've also partnered at the state level across departments of health, departments of education. We've accessed resources in the private sector as well, and this seems to be an issue that people have been able to come together around and really show how that's been done. So that's been an excellent outcome for us.
That's great. That's a great model for us to use into the future. And Dr. Terplin, I know this question was posed to Dr. Patrick a little earlier in the subcommittee hearing, but I would like to get your take on the type of innovative treatment models that are needed to close the gaps in research and programming for pregnant women who are addicted to opioids.
So I think we know a lot of the pieces that work. Medication-assisted treatment for opioid-dependent women, which is methadone or buprenorphine. We need to think about there's a third medication that exists, Vivitrol, is the brand name, and that has not really been studied in the United States in pregnant women. And having options is key. I think we get a little hung up, one versus the other, as if having a choice is an impediment rather than actually something that's great and liberating clinically and allows us to actually be able to individualize therapies better. I think we also have to work on, it's not just the medication, it's also the other associated services. Pregnant women with substance use disorders are a unique population in addiction medicine and come with a whole host of needs. Psychosocial needs, transportation needs, childcare needs, and things like that. And we have to find ways to integrate those into treatment and find ways to reimburse for some of those things, which aren't traditional medical services.
Thank you, Dr. Terplin. And Dr. Kurtzberg, again, thank you for being here, representing Duke Medicine and the Cord Blood Bank. Now, with the Cord Blood Bank at Duke, the Carolina Cord Blood Bank and the licensing that the FDA put forward in 2012. Can you tell us what the impact of that licensure has made on the Cord Blood Bank?
Yeah, the licensure process has been challenging, in large part because this is the first hematopoietic stem cell source that's been licensed, and it's been a learning process on both sides of the fence. But the bottom line is that licensure has increased costs of running a bank, and because of that, banks are using more of their limited resources to comply with some of these regulations as opposed to put more cord blood units in the bank and collect more units from donors. So we're hoping there could be some conversation with the FDA to help optimize the guidelines to apply to cells, since most of these guidelines are really written for drugs, and to both keep the high quality of cord blood units but enable more resources to go into collection and storage.
And again, you know, I just truly appreciate you being here testifying with our subcommittee here today on HR 2820. And there again, can you just talk a little bit about the difference between the cord blood stem cells and the embryonic stem cells and what that means to the future of research and the role that you are playing?
Well, cord blood cells are not embryonic cells. That's the first important thing to say. And cord blood cells can be collected without any risk to the mother or the baby, and in fact, they used to be discarded as medical waste. So we're literally recycling something that used to be thrown in the trash to save lives. So there is no real common or similarity between the two cells. Cord blood cells cannot give rise to every cell in the body. Cord blood cells are blood stem cell and progenitors, and they help reconstitute bone marrow after transplant.
Well, thank you very much, and I yield back the remainder of my time.
Chair thanks the gentlelady, and now recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to each of our witnesses for your testimony. I appreciate this opportunity that we have to come together to talk about these important public health bills. I want to especially focus, as I did earlier in remarks, on a program near and dear to my heart, the Hearing Detection Intervention Act. To reauthorize this important program, it's one as a school nurse I've worked on for over 15 years. Each year, more than 12,000 infants are born with a hearing loss. And since the first authorization of this bill in 2000, we have seen a tremendous increase in the number of newborns who are now being screened for hearing loss. Back in 2000, only 44% of newborns were being screened for hearing loss, and now it's a rate of over 89% before they leave the hospital. That's pretty astounding. We've also seen an increase in the surveillance and tracking of hearing screens and examination. The reauthorization bill I've introduced with Representative Guthrie would not only ensure this program is there for the children who need it in the future, but it would also strengthen the program based on lessons we have learned over this time. One such area where reauthorization would improve the program is the way in which it clarifies CDC's role in conducting surveillance on early hearing detection and interventions. I want to focus 3 questions on our audiologist on the panel, Dr. Martin. You're the audiologist at Arkansas Children's Hospital, and I'm going to ask you 3 questions, if you could be fairly brief so we can hopefully get these in. What is an example of the surveillance conducted by CDC and in which we have now seen gaps in addressing hearing loss? What has come out that reveals areas that we need to work on?
So one of the things that the CDC does is helps us set benchmarks of what we want to try to track among states and then compare those. And so one of the most important numbers that we've seen come out of that work has been the loss to follow-up rates. And we've made really tremendous strides in the last few years because there's been funding available to help states look at loss to follow-up. We've reduced that number by 50%. There's still babies who are lost to follow-up, and we're continuing to work on that. Some of those lost to follow-up babies are not actually lost to follow-up. The EDDI program coordinators know those babies. They know where they are, and their families have opted not to follow up for some reason, either financial or access.
Let me push that a little further, or just entice you to talk a bit more about it. While we are screening babies at a higher rate and we're doing better at follow-up, there still is a challenge, as you say. So follow-up care for newborns diagnosed with a hearing loss, this is such a critical time to get that intervention. How does this bill increase the likelihood that they're going to receive the appropriate follow-up care?
One of the things that it does is it expands the way that we can share information among states and among providers, and it guarantees that we, ensures that we really make access for families easier to find. We've had some programs put in place that have been collaborative between American Speech and Hearing Association, American Academy of Pediatrics, that helps primary care physicians and parents find audiologists so that they can get good follow-up and be connected to services more quickly.
And maybe you said this sufficiently, but if you could, there's a minute and a half left to elaborate on the importance of these programs, for focusing now on the parents, because many of the parents are hearing parents, and so this is all totally new territory to them.
Absolutely, brand new territory to them. 95% of children who are born with hearing loss are born to hearing parents, and so they have really little or no contact prior to that time with anyone who's been deaf or hard of hearing. And so the great thing about the reauthorization is it really recognizes the role of the family. So we figure that the family is the expert about their child. It puts the family in the driver's seat to make decisions. It sets up programs and systems where we provide information to these families so that they can make informed choice, and it helps engage them in the process. So it helps them be their child's first teacher, the expert on their child, and really help them to partner with the different agencies in ensuring that their desired outcome for their child is the one that they get.
Well, if that isn't reason enough for us all to support this legislation in the reauthorization, I appreciate your answering these questions. I do, Mr. Chairman, wish to submit for the record a letter from the American Academy of Pediatrics supporting the reauthorization of the Early Hearing Detection and Intervention Act. I'll submit that for the record.
Without objection.
I'll yield back my time.
Without objection, so ordered. Chair now recognizes the gentlelady from Indiana, Ms. Brooks. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you for calling this important hearing on public health issues. The Indianapolis Star, and I represent Indianapolis and to the north, a columnist by the name of Matt Tully has been doing quite a bit of series on the opioid and heroin addiction plaguing our country. And a recent article cited some startling statistics that the epidemic's having on hospitals in Indiana. So I'm very, very pleased that you're here. At Eskenazi Health, a hospital in downtown Indianapolis, officials say the hospital's on track to see a 22% increase this year in the number of newborns experiencing narcotic withdrawal. A doctor at St. Vincent's, a Northside Indianapolis hospital, said between 20 and 30% of the babies admitted to the NICU suffer from drug dependency, 20 to 30%. And obviously, and as Matt Tully has wrote of a 5-day-old at Franciscan St. Health on the south side of Indianapolis, so this knows no geographic boundaries in our community or in our districts, who was receiving morphine treatments because his body was shaking so bad, and that he was racked with diarrhea so bad that it was affecting his skin, and it was just horrible watching the withdrawal, which actually this columnist was seeing. But I think what I've learned today, Dr. Turplin, you indicated the babies can stay in the hospital for an average of 3 weeks when they're going through this type of withdrawal. And I must say that Representative Kennedy and I just recently introduced a companion bill to the Senate, to Senators Kennedy and Ayotte, or I'm sorry, to Senators Donnelly and Ayotte, of the Heroin and Prescription Opioid Abuse Prevention Education Enforcement Act, and it's a multi-pronged approach, and it focuses on a number of things, including interagency task forces to try to get better prescribing practices, specifically focusing on our prescription drug monitoring programs. But I have to tell you one thing. I'm a former U.S. attorney. I've been involved in the criminal justice system most of my career, and I appreciate that punitive approaches aren't appropriate, as you say. However, many of these women are in the criminal justice system or find themselves in the criminal justice system, and I'm curious what you think our approaches should be with those who are in the criminal justice system. They're in there, in all likelihood, for other crimes they're committing during this time, or maybe for being arrested for dealing or for possession. And so what approach do you think should work specifically for our children in our jails and our prisons with respect because there are a lot of them. And so this is the hospitals, but I think if we talk to our sheriffs around the country, they are experiencing these issues too. What is the best approach that we should have for the so many pregnant women in our jails and prisons?
That's a great question. And our jails and prisons are the largest behavioral health care systems in the United States, unfortunately. And there are, I've spoken of barriers to access to medication-assisted treatment amongst pregnant women in general. Those barriers are far higher in prisons. So some of it has to do with how prisons are financed and the cost of medications. Even though cheap, methadone across a huge population of prisoners who need it is a costly thing. So I think what we really need is access. The prisoners and people in detention need access to behavioral health care in general, and for opioid use disorders to medication-assisted treatment in particular. And additionally, we need better linkages from release into the community. So right now in state of Maryland, only individuals who are arrested and are on methadone receive methadone in the jail. People who have an opioid use disorder come to jail and they withdraw. We know withdrawal for pregnant women is dangerous to the fetus. And we need to find ways to provide medication and other counseling services and then linkage into, upon release into the community.
Dr. Patrick, do you have any thoughts on our jail and prison issues with pregnant women?
I would just echo the access to medication-assisted treatment when it's needed for pregnant women is really the standard of care and improves infant outcomes as well.
Have you done any work with our drug treatment courts? Because a lot of times those judges who are presiding in the drug treatment courts see the same women. They may or may not be in jail, people who, or prisons who are in the drug treatment courts. And I know that we have struggled with learning whether or not some believe in abstinence as the best method, but certainly have you done any work in following drug treatment courts or advising drug treatment courts?
A little bit in Baltimore City, and mostly around educating not just all of the staff, but especially the judges, and also the judges who aren't drug court but might be subbing for somebody else, around the importance of the evidence base for treatment for substance use disorders.
Thank you. I yield back. Thank you.
Chair, thanks, gentlelady. We're about to see another vote series, so we'll try to move this along. Chair recognizes Ms. Matsui of California, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you for the witnesses for being here today, and a special thank you to Dr. Chow and Dr. Kurtzberg for testifying today about the importance of the National Marrow Donor Program and cord blood banking. Every 4 minutes, someone is diagnosed with blood cancer or another blood disorder. Often the only cure for these fatal diseases is a bone marrow or a cord blood transplant. Congress has recognized the national need for bone marrow transplant since 1987, and 10 years ago formally added the National Cord Blood Inventory to the C.W. Bill Young Cell Transplantation Program. A big part of the Stem Cell Therapeutic and Research Act is the National Registry, known as Be the Match, which matches as many patients as possible to bone marrow or cord blood donations that they need. And during the last 30 years, the registry has grown to include over 12 million adult volunteer donors and over 200,000 cord blood units donated by moms after the birth of their children. The growth of the registry over the last decade is promising, but we know we must continue our efforts to encourage donors. Dr. Chell, as you mentioned in your testimony, some of the roles that the National Marrow Donor Program plays in addition to running the National Registry. Can you elaborate a bit on all the work that Be the Match NMDP does?
So we are responsible for a network of centers all over the world that help recruit donors and recruit moms to donate their cord blood, to create that inventory. And yet that inventory, despite having 25 million donors worldwide and over 600,000 cord blood units, is really only meeting less than half of the need in the United States and only 5% of the need worldwide. And that's because the population of the United States as well as the world becomes more diverse. And so that diversity requires us to continue to add more donors to the registry. but we also advocate from patients from the time of diagnosis through survivorship, through multiple languages so they can get the education and information they need. Through the SCTOD portion of the contract, we create the infrastructure and the reporting mechanism so that we can collect data on every single transplant done in the United States and 60% of the transplants done worldwide, so that researchers from all over the world can enter that database and help us to find new ways of using these therapies and rapidly turn those discoveries into use throughout the world. We also work as a cord blood coordinating center to manage the relationships with the cord blood banks, as well as multiple centers that recruit adult donors.
Okay, thank you. Dr. Kurtzberg, as you know, the goals in creating the NCBI were to create a network of high-quality, diverse cord blood units and to make cord blood units available for research. Can you elaborate on the work that you do to meet these goals?
Sure. I run a public cord blood bank named the Carolinas Cord Blood Bank at Duke and work every day to collect cord blood units from moms who donate their baby's cord blood after a healthy pregnancy and delivery. We also work to develop new models to increase the opportunity for cord blood donation for moms of minority backgrounds. We've opened a program recently at Grady Hospital to do that. We're looking at ways to decrease cost of cord blood donation and banking, which is always an issue in the field. And we're looking at ways to apply cord blood transplantation to new diagnoses.
Okay, thank you. Dr. Chow, you mentioned that the number of transplants for racial and ethnic minority patients has increased substantially from the year 2000 to today. And I just want to follow up on what my colleague, Mr. Butterfield, was talking about, because he mentioned the African American population. I know that the Asian American population is feeling a great need, and you see these individual type activities move forward, trying to find a match. What efforts can be the match made to continue to increase the diversity of the registry to ensure the minority patients can find matches, understanding that this country itself is such a diverse country that we need to figure out a system. I think there's a lot going on, but what do you think you can do to help increase the diversity of this?
I think it's important also to raise awareness. If we're to take a Caucasian donor, a Caucasian patient as well as an Asian American patient, if they are in the right healthcare system and get access to a search, the likelihood to move on to transplant is equal. The challenge is many Asian Americans don't have access to that first initial step of doing a search, being in a healthcare system to do that search. But with that, we need to, across all ethnic groups, significantly increase the diversity of the registries. For Asian Americans, we also benefit from having partnerships with China, Japan, Korea, Hong Kong, and other countries to allow us to increase the diversity. For African Americans, we don't have partners in African American countries that help us with the diversity.
Well, I know my time is up, so thank you very much.
The chair thanks the gentlelady. We have less than 10 minutes, some minutes left. We're going to try to conclude the hearing. Chair recognizes Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate very much for holding this very important hearing on some really good bills. Dr. Martin, in the interest of time, I really have a lot of questions, but we'll start with the hearing loss screening. You stated that the number of individuals who have lacked follow-up care from their initial screening has been reduced by half over the past 10 years. H.R. 1344 states that one purpose for which states can use funds is to develop models that will ensure babies identified as needing follow-up care receive those services. My first question is, what are the challenges for a child who does not receive follow-up care with an early intervention provider, and how is it harmful to the child?
There's this critical period for children to acquire communication that really, birth to 3 is the most critical time period. And so we've seen rapid improvements in the outcomes for children when they enter the educational system, and their long-term outcomes if they've been identified early within the first year of life as compared to children who are identified after that. So kids who are lost to follow-up, fail their newborn screen, and then show up in the pediatrician's office at 3 or 4 or fail a kindergarten screening, then are already significantly behind their typically hearing peers and are really going to have a difficult, if impossible, time catching up from a linguistic sort of base and from a psychosocial base as well.
Thank you. Question for Dr. Patrick and Dr. Turplin. Counties within my district were found to be suffering from some of the highest numbers of babies born with neonatal abstinence syndrome. What practices have been successful at addressing this issue in other regions? How would this legislation help those at-risk populations?
Well, as far as treating infants with neonatal abstinence syndrome, the practices that have been most effective have really been around standardizing care and working together through networks of hospitals and neonatal intensive care units. That's really been effective in making sure that we're treating these infants the same collectively. I mean, through the bill brings together data and evidence. It also brings together a multidisciplinary group of people to think about how we attack every part of the problem, including before pregnancy, in pregnancy, and in the treatment period for the infant. So I think we'll see a positive effect in communities like yours and mine as well.
Thank you. And Mr. Chairman, I'll submit the questions for the record because I want everyone to have an opportunity. Thank
Chair,
you very much. I yield.
Thanks.
Thank you.
Chair, thanks, gentlemen. Now I recognize Ms. Castor, 5 minutes for questions.
Thank you, and I thank Mr. Bilirakis as well. And I want to thank our witnesses for being here today to testify on these important public health bills. I want to thank Representatives Clark and Stivers for their work on H.R. 1462, especially Protecting Our Infants Act of 2015. I'm a co-sponsor of the bill, and I think it's clear that we need additional efforts and resources to address the challenges of neonatal abstinence syndrome. And the bill before us does that in many critical ways. Mr. Bilirakis and I share the counties, and I just want to get this on the record. In 2007, our counties had 67 reported cases, 2008, 108, and by just 2011, about 280 reported cases. So we've got to do more. These are the questions I'd like you to answer for the record. According to the GEO report, there are a number of existing research gaps relating to best practices in the screening, diagnosis, and treatment of NAS. You've discussed them. If you would also discuss them in more detail in written testimony. Dr. Patrick, what do we know about the best practices in screening and diagnosis and treatment, and what are the most pressing research gaps? How does the Protecting Our Infants Act help to address the gaps? And then if you could also share in written response, are we underinvesting in research related to NAS given the significant public health burden that it presents? Thank you all again for being here today, and I look forward to your written response.
Well, your first question about best practices, and I think it begins with identifying the infant. So it begins with that transition from pregnancy to the infant being cared for. We have to know the infant's been exposed, and so screening, universal screening through both verbal and standardized verbal screenings as well as diagnostic screenings. We using the same scoring system to identify and being consistent with that. Treatment, it's clear from the evidence that using an opioid like methadone or morphine is the most effective, though we see some hospitals using other drugs like phenobarbital that may actually have some long-term harm.
I think I'm going to cut short so Mr. Collins can do it, but I do want to express my gratitude to all Children's Hospital and St. Joseph's Children's Hospital and all of the medical professionals across the country who are tackling this issue, and I yield back the balance.
Chair, thanks, gentlelady. And you can respond more fully in writing to that question. We'll provide the questions to you in writing. Thank you. Mr. Collins, you're recognized. We have 2 minutes left on the floor.
Well, and I'll be quick. Luckily, they always hold votes over. And also, if you could, I'll direct this to Dr. Patrick, perhaps answer in more detail. I'm one of the co-sponsors on H.R. 1462. Your testimony here has done a great job in showing the importance of reauthorizing these. What I'd like you to perhaps respond in writing is some of the differences between NAS and fetal alcohol syndrome. We know about those. If you could maybe compare and contrast what's going on in those two fields, I think that would be helpful to truly show the importance on the opioid abuse, which we've had several oversight hearings on. And maybe simply, also, could you just confirm, verbally now, is a child born with NAS impaired for life, or are the treatments in fact moving them into what could be a normal life?
And there's no evidence that the infants are impaired for life. There have been some subtle evidence of some behavior issues. It's definitely an area that needs to be more well studied, but I think it would be very unfair to say that the infant is affected significantly for life.
Well, and that's what I would hope you were saying, so the treatments, in fact, are life-changing, and that's what we're all about here. So, Mr. Chairman, I yield back, and I guess we'll go down and vote. And be done for the week.
Chair, thanks to the gentleman. We will provide questions in writing from those of us who are here and those who were in other hearings. We'd ask that you'd please respond promptly. We thank you very much for your patience, for all the interruptions. Really a very interesting, very important hearing. I have a unanimous consent request. I'd like to submit for the record statements of Doris Matsui, Jean Green, and the American Academy of Pediatrics. Without objection, so ordered. I remind members they have 10 business days to submit questions for the record. Ask the witnesses to respond promptly. The members should submit their questions by the close of business Thursday, July 9th. Thank you very much for this very important testimony today. Without objection, this hearing is adjourned.